Hello, and welcome to the RSNA Radiographics podcast. I'm Maya Nikolic, a PhD student at McGill University, and today I'm joined by Dr. Maran Halou and Dr. Eric Terrasse from the Université de Montréal. Dr. Halou is a pediatric and adult interventional radiologist at CHU Saint-Justine and the CHUM, and Dr. Terrasse is the head of interventional radiology at the CHUM. Today we're talking about pulmonary arteriovenous malformations, or PAVMs. And I want to start with the big idea. These are small vascular shortcuts in the lung, but they can have major consequences for the brain. A PAVM is not just an abnormal vessel. It is a bypass of one of the lung's most important jobs, filtering blood. So Eric, let's start there. What exactly is a PAVM?
A PVM is an abnormal direct connection between a pulmonary artery and a pulmonary vein without the normal capillary bed in between. Normally, blood passes through the tiny capillaries in the lung. That is where gas exchange happens, but it is also where the lung acts as a filter. In a PAVM, blood skips that filter. Structurally, you usually have three parts: a feeding pulmonary artery, an aneurysmal sac, and a draining pulmonary vein. The problem is that thrombi, bacteria, and air bubble can pass directly into the systemic circulation. That is why PAVM are associated with stroke, transient ischemic attack, and brain abscess.
So the lesion is in the lung, but the complications are often neurologic. That is the key teaching point. The lung is supposed to protect the brain from things that should never reach arterial circulation. Marin, what do these patients usually feel? Are they symptomatic?
Many patients are actually asymptomatic. Today, PAVMs are often found incidentally on CT imaging done for another reason. When symptoms do occur, they can be subtle: mild shortness of breath, fatigue, migraines, or reduced oxygen saturation. In larger or multiple PAVMs, patients can develop hypoxemia, dyspnea, cyanosis, or clubbing. But the major issue is that even patients who feel well can still be at risk for serious complications.
That makes imaging critical. Before we get into imaging, let's talk about HHT, because PAVMs and hereditary hemorrhagic telangiectasia are closely linked. Eric, how strong is that association?
It is very strong. More than 80% of PAVM was associated with HHT. HHT is an autosomal dominant vascular disease caused by mutation in genes such as ANG, ACVR1, SMAD4. Clinically, we think about the curvature criteria: recurrent nosebleed, mucocutaneous telangiectasia, visceral arteriovenous malformation, and a family history. So when we diagnose a PAVM, we need to think about HHT. And when someone has HHT, we need to screen for PAVM. When HHT is diagnosed, other members of the family should also be tested.
Now, Marin, let's classify these PAVMs. What are the main types?
There are three categories: simple, complex, and diffuse. A simple PAVM has one feeding artery, one sac, and one draining vein. They are the most common. A complex PAVM has multiple feeding arteries. Diffuse PAVM are much more rare. Instead of one focal lesion, you have multiple and diffuse small PAVMs involving an entire segment, a lobe, or even a lung. They are much more difficult to treat too. There is also the telangiectatic pattern, which may appear as a ground-glass nodule on CT and may represent an early stage of PAVM development.
That framework matters because treatment depends on the classification. So now let's move on to imaging. How do we make the diagnosis?
First, we do a transthoracic contrast echocardiography, also called TTCE. It's the screening test for all the new HHT patients. TTCE does not show the PAVM directly. It detects the right to left shunt by showing the microbubbles going to the left heart after injection of agitated salines through the veins of the arm. If the bubbles appear very early, that's not a PAVM, probably more a cardiac issue. If they appear later, it suggests a PAVM. After a positive TTCE, we go to the CT.
And CT is where you can actually see the lesion.
Yeah, exactly. We use a non-contrast chest CT. Non-contrast is important because it avoids the risk of paradoxical air embolism, like little bubble coming from the IV lines. On CT, the classic PAVM looks like a vascular nodule connected to a big feeding artery and with an enlarged draining vein. We use a lot MIP reconstruction. It helps to make the diagnosis.
Eric, once we identify a PAVM, who should be treated?
Well, the modern principle is that all treatable PAVM should be embolized when technically feasible. Historically, small lesions with feeding artery under 3 mm were often observed. But we now know that even small PAVM can be associated with stroke or brain abscesses, especially when there are multiple lesions. So the question is no longer simply, is it big enough? The question is, can we treat it safely?
And before the procedure, what are the key preparation steps?
The first step is to get a neat CG, because if the patient has a left bundle branch block, the catheter manipulations in the right ventricle can lead to a right bundle branch block. And so a left bundle branch block plus a right one means a cardiac arrest on the table, and nobody wants that. So in those patients, we should put a pacemaker before doing the intervention. And we also have our usual checklist like contrast allergy, coagulopathy, etc. For the antibiotics and the anticoagulation, depend on the center. Like for anticoagulation, some colleagues give anticoagulation to avoid any thrombosis during the procedure, while others do not give anticoagulation because of the risk of bleeding in HHT patients.
Now let's talk devices. This is one of the most useful parts of the article, plugs versus coils. Maren, how do you choose?
The choice depends on the anatomy, feeder diameter, vessel tortuosity, and how distal we can get, and whether there is enough landing zone to put the plug.
So let's start with plugs.
Bare metal plugs, such as Amplazo plug or AVP, are useful for the largest feeders. They are stable, controlled, and have a low risk of migration. With AVP, we usually oversize by 30 to 50% because pulmonary arteries are very deformable. But there is limitation. AVP second generation require large guiding catheter to be delivered, which is not always possible in small vessel. There is also the membrane-covered plugs, such as microvascular plugs. They are very useful in smaller or more tortuous anatomy because they can be delivered through microcatheters. But the sizing philosophy is different. They should match the vessel rather than be oversized.
And coils?
Coils are very useful for smaller distal or tortuous vessels. They allow us to embolize very close to the sac and sometimes even within the sac itself. The distal embolization is important, very important, because proximal occlusion can allow reperfusion through collateral pathways. Different coils behave differently. Fibered coils promote thrombosis within the nylon fibers. Hydrogel-coated coils expand within the blood and increase occlusion. Platinum coils are the least efficient because they only rely on mechanical packing. In practice, plugs are often preferred for larger accessible feeder, while detachable O18 coils remain very useful for distal or difficult lesions.
Now let's walk through the procedure.
The procedure usually starts with femoral venous access under ultrasound guidance, light sedation, and careful sterile technique. Sedation has to stay light because the patient may need to hold their breath. A sheet is placed and we use continuous saline infusion with air filters. It is essential because any air bubble can pass through the PAVM and reach the systemic circulation. A pigtail catheter is advanced through the right heart into the pulmonary artery. We measure pressure, perform angiography, and map the anatomy. Then we catheterize the feeding artery with O18 transient micro guide and directly the soft tip guiding catheter. When we are all well positioned, we deploy the embolic device and as distally as possible, ideally at the entrance of the sac.
Maren, during the procedure, what are the small details that matter?
First, when a catheter, wire, or anything is withdrawn, saline is injected to replace the dead space and to prevent air entry. Second, we shape the transom, the microguide, with a tight G curve to reduce the risk of vessel perforation. Third, after device deployment, we just inject contrast very lightly to not dislodge fresh thrombus. Last tip, ask the patient to take a deep breath to straighten the vessels, and this is allowing to advance the guiding catheter more distally in the artery. If we can't advance with the microguide and the guiding catheter directly, we change for a triaxial system with a 4 French catheter and a microcatheter within the guiding catheter. If we still cannot advance the guiding catheter to deliver a plug, we simply use only the microcatheter and we embolize with MVP or with coils instead of a big plug.
What changes in complex or diffuse disease?
In complex PAVM, multiple feeders have to be treated individually. Some may be suitable for plugs, others for coils. Diffuse PAVM are much more challenging. There may be innumerable small fistula. Treatment often requires multiple sessions, and residual shunting may persist despite aggressive embolization. In severe diffuse cases, multidisciplinary management is needed and surgery may be discussed.
Let's talk about complications. What should listeners remember?
The most common immediate complication is pleurisy, often due to small pulmonary infarction. It usually causes chest pain and resolves with conservative treatment. More serious complications such as vessel perforation, hemoptysis, pneumothorax, and paradoxical embolism are rare. But because the risk of stroke, the entire procedure is designed around preventing air clot and device migration.
So the technical details are very important for safety. How successful is embolization?
For simple PAVM, the outcome is excellent. Technical success is very high, and most treated PAVMs remain occluded. But follow-up is essential because persistence can occur, especially in complex PAVM.
And what causes persistence?
There are 4 mechanisms. The first is a recanalization through the embolic material, especially if coils are insufficiently packed. The second is reperfusion through an accessory feeder not seen during the embolization, which can happen in complex PAVM. The third is pulmonary to pulmonary collateral reperfusion, where adjacent pulmonary arterial branches supply the lesion, happening especially when the PAVM is embolized too proximally. The fourth is systemic to pulmonary perfusion from bronchial, internal mammary, intercostal, or subclavian arteries. This type has an increased risk of hemoptysis because of the high systemic pressure. The main prevention strategy is good initial technique. Embolize as distal as possible, which means embolizing the distal feeder with plug or the sac with coil and make very dense packing.
Pregnancy is another key topic. Why are PAVMs especially important in pregnancy?
During pregnancy, cardiac output increase and vascular resistance decrease. This hemodynamic change can enlarge the PAVM and increase the risk of complication, including hemothorax and stroke. Women with HHE who are planning pregnancy should be screened for PAVM before pregnancy, and PAVM should be embolized before. If a large PAVM is discovered during pregnancy, the treatment is generally postponed to the second trimester unless emergency bleeding.
So now let's move on to the take-home messages. Eric, do you have anything to say about that?
My message is that all treatable PAVM matter. Even small lesions can cause serious complication. Embolization is highly effective and very safe when performed carefully.
And my take-home message is always think about HHE while discovering a PAVM. A PAVM may be the first clue to a family disease with implication for the patient and for all the family.
Dr. Halou, Dr. Terrasse, thank you both for joining me. And to our listeners, if you're reading this article, look carefully at the figures and animations. They are not just illustrations, they are part of the learning process. Thank you for listening.